trying to treat the patient the way I tell my colleagues, the way you would treat like your best friend or your close family members, because you would go above and beyond for them, right? But if you wouldn't do that for a patient, I would argue you're in the wrong field then.
Welcome to That's Derm Good. I'm Janelle Ball, and I'm excited to bring you thought-provoking conversations about biologics, specialty medications, treatments, and so much more. I'll be chatting with some amazing guests about access, affordability, and advocacy. You're really going to enjoy this show. Today, my guest is Dr. Diego Ruiz Dasilva. Dr. Dasilva is a board-certified dermatologist at Forefront Dermatology and a clinical professor at the Eastern Virginia Medical School. Welcome, Dr. Dasilva. Thank you for joining me.
Thank you so much for having me, Janelle. Excited to chat with you today.
Yes. I appreciate you taking time out of your day, seeing patients, and I'm sure you've got a million other things going on. You're pretty busy seeing patients and also teaching. So tell me a little bit about what sparked your interest into the derm space when you went to medical school.
Yeah, so really it started a bit earlier than that for me. So, early high school, I had really severe acne, and that's kind of my first, personal introduction to dermatology. And it was a bit of trial and error in terms of seeing some people who just, you could tell were just trying to get me out of the office quickly, give me a topical and move on. And a lot of the same things I was given over and over again that didn't work. And then I had an awesome dermatologist who started me on Accutane, and that was literally life changing for me. I went from someone who I barely have photos prior to the age of 15. Like I didn't want to be in pictures, majorly self conscious, like terrible self esteem, just to kind of brighten up my personality, make me more outgoing, more comfortable in crowds and with friends and public speaking. So it truly changed my life. And just to see that impact that dermatologists could have on someone's life made me think, what a interesting job. What a cool job that you can do this, even though it is visual, and a lot of times people think like, oh, this is just an aesthetic thing. There's such a larger piece of it, right? When you're talking about like social and emotional health and mental health and kind of the full holistic care of a patient. So when I started medical school, I kept an open mind to everything, and I honestly kind of like everything. I'm a people person. I like helping people. I like talking, meeting, learning. Dermatology still captured my heart between that experience I had as a young person, family members with a lot of skin cancer that I would help take the visits when I was younger, and then the variety of what we see. We get to be medical, we get to be aesthetic, we get to be surgical as well, and get to have a decent lifestyle in terms of not sleeping at the hospital every night, like some of my friends. So shout out to them
Right.
because they work a lot, but I'm very happy with dermatology.
Right. You said something really interesting about acne and it being not just cosmetic. It's something that really does affect people mentally. It affects, especially as a child, growing up. I dealt with that myself a lot in, even some family members. How does your approach now when you see kids coming in, you can relate to? They probably come in thinking, oh, well, you've got perfect skin. You don't even understand how I feel. How do you make them feel comfortable and show them your perspective?
Yeah, I think for me, it's just being super patient centric in terms of how much they care. I think like many things that we treat in medicine and certainly in dermatology, certain patients can have a decent amount of acne or whatever condition, right, and be not that bothered by it, and that's fine. I don't ever want people to feel ashamed or to self consciousness. But for a lot of patients, it's opposite. Of course, they're incredibly bothered and they feel like other people think it's no big deal. And so I tell them, I'm like, hey, I went through this like as a teenager. My acne like really ruined my life. I didn't want to take pictures. I didn't want to like interact with friends, play sports, etc. And so I take acne very seriously. So I'm ready and willing to be as aggressive as you'd like in terms of combination between topicals, oral medicines, lasers, etc. Or to do as little and keep it simple if that's what you prefer too. But we're going to work together here, and I'm not going to give up. So if in a few months you're not exactly where you want to be, I want you coming back so we can adjust things, and we'll continue to adjust things until you're happy. So it's kind of like, validate how they feel, but also tell them that this is a continual process we're going to work on. Because I think
Hmm.
sometimes we've all been disappointed, right? You try something and you expect this awesome result. And then you're like, it's a little better, but maybe I need to give up. Like that's it. I saw the doctor and it's not where I want it to be. And I don't ever want people to lose hope.
Yeah. Accutane is pretty intense process. When is it something where you're okay, you definitely need to go and Accutane? Is that like a first go to when they come into the office, or do you usually say, let's try a couple other topicals first and then?
Yeah, it really depends. So, like, some folks come in with really severe inflammatory acne, like, those really deep cysts and, significant discoloration or scarring already present in the skin, like early scarring where it looks a little pitted or like
Hmm.
rolling scars, in which case, especially, we're talking, 13, 14, 15-year-old, I'm thinking about this person at 25, 30, 35, the way they view themselves and how scarring can affect people, right? When you see them out in the public. And so at that point, I'm already discussing, right? I don't ever like for people to feel forced to do anything, especially something like that where you need monthly visits and blood work and all these things, right? But I just already tell them, I'm like, hey, listen, you have early scarring changes. Like, I do think that we can reverse this and make things way better, but we should either consider Accutane now or next visit after trying X, Y, and Z first. So that way they're kind of primed to think about it already. More often, patients come in like right in the middle where I'm like, it's bad acne, but like I don't see any evidence of scarring yet. And I'm like, all right, if you want to take this with a topical route, I think that we can get you better as long as you're dedicated with the regimen. And then it's just really seeing them back sooner. It's not saying come back in a year, come back in 6 months. It's like three to 4 months to get an idea of how well something's worked. Because
Hmm.
I've had those patients where it's just a miraculous response to a basic treatment regimen with a morning and night topical and a wash, where they come back and I'm like, all right, great, you're golden here. Just keep up with it through your teenage years.
What happens if it just doesn't get treated? Does it go away as you get older? Is it hormone related? Like, how does that work? When you had severe
Multiple
acne at a young
factors.
age.
Yeah, like you said, there's multiple factors. I mean, I think hormones and genetics play a huge role. So can environment and activities like, of course, like occlusion and sweat and bacteria and that sort of thing. But I think it's kind of a global package. And certainly the hormonal acne that tends to occur with teenagehood, people do grow out of. I'd say a majority, a far majority of patients do. But the thing is, they can have a ton of scarring by the time that's all done, right? And then literally never have acne again for their whole life, but those scars are permanent. And then, of course, I always hesitate to tell people like, oh, don't worry about it, you just grow out of it, because there are some patients, usually it's our female patients because of, of course, menstrual cycle and different hormonal profiles where they might have had clear skin all throughout their teenage years, and now they're 19, 21, 25. I think it's kind of meeting them where they're at.
Yeah. The scarring part I think is difficult. How do you treat the scarring after the acne's gone?
Yeah. Yeah, and of course there are some amazing treatments for that. Like, some for milder scarring, I really like just regular pen microneedling that doesn't have any energy or lasers involved because it's relatively affordable, low downtime. People look like they just got a little bit of like redness and irritation right after for a couple of days. So it's something where you can still be working, going to school. You don't really need to, stay at home or recover. But for folks with more moderate to severe scarring, you're really talking multimodal therapies like aggressive resurfacing lasers, like a CO2 laser,
Mhm.
subcision, which is essentially cutting using a sharp needle underneath the skin to try to free up the scar tissue. Chemical peels. It's kind of like a variety of different things. And
Mhm.
what's of course challenging there is that it's a true medical disorder that's caused the scarring, but then the scarring itself is considered cosmetic, right? So
Mhm.
insurance companies do not pay for any of these treatments.
Mhm.
And of course, if you're in Hollywood, I guess you can buy the laser yourself and just have it out. But for most of our patients,
Right.
that spending, anywhere from $5,000 to $10,000 to treat acne scarring is just not an option for them.
Right. Yeah. So it's best to kind of get it under control early on before it does get worse, and then
Yeah.
you've got a lot, more to worry about. So you trained at some incredible institutions, the University of Miami, University of Pennsylvania. Was there a moment in residency when you thought, yes, this is exactly where I'm meant to be, or you already knew that ahead of time, so you kind of went into it saying dermatology is going to be my specialty?
Yeah, but I'd say that evolved. So like, I came in with that passion. Like I said, I liked a lot of different things too, so I was open. But ultimately, I consider myself an acne expert, and I treat a lot of acne. I fell in love with treating itch.
Mm,
So itch really became atopic dermatitis. Our eczema patients, our patients with urticaria and hives, patients with chronic pruritus of unknown origin, which by definition is kind of these patients who are just itchy for years on end, and we don't really know what's causing it. I noticed a similar pattern, kind of like how that severe acne can cause patients to become withdrawn, to become depressed, to not want to be social, to not be able to do all their normal things that human life. This is what happens to severely itchy patients, right? They have difficulty holding down jobs, they have difficulty going on a date, they can't sleep, particularly because of the itching, and so they're either always cranky or it's messing with their mood, they're getting depressed, anxious, suicidal. And then I also noticed at the time, like, not a lot of experts or passion around treating itch. It's definitely gotten more prominent over the last 10 years, like since I've been out, because we have awesome medications now approved to treat lots of itchy conditions. But at the time, it was like light therapy, steroids, immunosuppressants, and it was very much almost discouraging patients. Like, hey, I can give you this aggressive medication, but you probably just try to live with the itching because. So I found this like need for that, and I really fell in love with helping those patients. Happened to be at the University of Pennsylvania at that time, where there was awesome mentor. Shout out to my mentor Nicholas Melanizar, who's an awesome doc there, and he had trained under the great Gil Yosipovich, what we consider the godfather of itch. And I learned a lot of useful pearls. I got to run a specific itch only clinic where we would see patients from all around the surrounding Philadelphia area, referrals from 100 different dermatologists, and got to learn a lot and help these patients. And it really encouraged me for my future. And so, like now in my job as a general derm, again, I see everything, but I always have a special place in my heart for the itchy patients. And I have an itch clinic like intertwined with mine where I see referrals from my colleagues and the people all around Virginia Beach and the Tidewater area.
Yeah. It's so wild when you think about, okay, intense chronic itch. I can't even imagine, if you're not dealing with it, it's hard to even put yourselves in their shoes and understanding how it affects their quality of life. My side is working with the insurance. What are your experiences with that? Just from all the information that do you have any tools in your toolbox that you have used now because of what you know and what you've learned about itch and how it really affects patients and their quality of life, when it comes to fighting with the insurance and dealing with that?
Yeah, so you and I are kindred spirits on this because to me, my biggest pet peeve is when clinicians don't like treating this or seeing these patients because they feel like it's a hassle or it's like, oh, it's a paperwork and got to involve my coordinator and I got to write all these things down in my notes. And I would say the patient's the only one who suffers, right? Like they get to continue suffering while you, as the provider, presumably don't have that medical condition. The insurance company could care less; they're saving a buck, right? And maybe the office is saving a buck if they're not wanting to hire a bio coordinator or something like that. But then the patient's the only one left suffering. And I just think that's such a travesty. And so I truly fight against that. I mean, I'm always trying to tell all my colleagues about the treatments available, doing a lot of educating and speaking. But then when I'm seeing the patients, it doesn't matter how behind I am, how many patients are waiting. That patient in front of me is incredibly important. I'm going to make sure the note has all the things. So that's a particular itch score, right? It is whatever it is, but typically, a 7 and above is severe, right? Making sure that their IgA, let's say atopic dermatitis, they're at least a moderate 3 or 4, right? That I'm documenting these quality of life measures. I'm not just saying those things. I'm saying, patient has had this for X amount of time. They have trouble sleeping. This has affected their mood and their, ability to be like a productive human. And basically documenting all these other things, right? They've been giving steroids many times over the years. Studies show that steroids cause increased risk of strokes and osteoporosis and heart attacks and all these things. Saying, so trying to find a safe FDA approved treatment because steroids and immunosuppressants are not FDA approved for atopic dermatitis or recommended. So I just make sure that I'm documenting all these things and that I'm working with my coordinator on appeals. When those times arise, doing peer to peers as well. So it's really just trying to treat the patient the way I tell my colleagues, the way you would treat like your best friend or your close family members, because you would go above and beyond for them, right? But if you wouldn't do that for a patient, I would argue you're in the wrong field then.
Yeah. When patients come to a doctor's appointment, they want to feel like they're cared about, that they're not just a number and they're like, okay, you got your 10 minutes with the doctor. Now it's time for you to go, kind of shuffling them in and out. So when they actually are able to talk with somebody that understands, that is able to really kind of get down to the bottom of the issue. Because I think a lot of times, you know, we go in and we're searching. There's so many people that are looking online to try to find those answers and figure out, okay, what is the quickest fix, and really just not really getting to the bottom of it. And I think being able to have somebody that can thoroughly explain things to them, I think that makes such an impact. And especially if they're being treated like family, it makes such a difference.
Yeah, 1,000%. And I think that, sir, I've had times where I'm so stressed, and I'm a human. So, like, let's say I have like, my own things going on in life, and I'm just it's a down day. I'm an hour behind, and there's itchy patients in front of me, and it's grandma, and I'm tempted to give her a jar of triamcinolone and say, just try this, even though you've tried this 20 different times, and come back, in 6 months. And I have to sit there and be like, no, like if a physician or PANP was treating my grandmother this way, I would be disappointed in them, right?
Hmm.
And you got to just take that step back and just then take the time and do what you need to do.
Yeah. Yeah, the quality of life. So when you have a patient is experiencing this itch, is it always presented with, with psoriasis? Can you always see everything on the skin? Say you were treated with, for eczema by, your primary care or something, and you're still experiencing itch. Is that normal?
Yeah, so I think that's the challenge that we've discovered over the last few years. There's been this disconnect that just no people didn't really talk about it, or we thought maybe patients are quote unquote crazy, right? Oh, it's in their
Mm-hmm.
head because their skin looks good. But I think now we know that yes, the itch can be linked to the skin symptoms, but you can also have really significant itch with complete absence of the rash, right? If you
Wow.
started with the rash, let's say the rash went away with a topical treatment, et cetera, but you're still really itchy, or just primary essentially inflammation in the skin, but that's not visible, right? It doesn't come with like, bumps or plaques or patches or anything like that or raw skin. It just looks totally normal. And I actually feel the most for those patients because I think when a patient comes in covered head to toe in eczema or psoriasis, almost any clinician kind of feels their inner dermatologist is like, all right, got to do something about this, or their heartstrings are pulled. But sometimes they come in just as miserable, but you don't see a lot, and it's kind of like, oh, maybe it is in their head, or oh, you got to
Mm.
just stop stressing, like go to sleep, don't use hot water in the shower, and you give them these like basic things, which sure they're healthy skin tips, but it's not going to work for everyone.
Yeah. Is it something internal, or is it always fixed by a topical?
Yeah, so I mean, there's a bit of a mix. What I'd say is the chronicity plays a strong role there, meaning there's a lot of research showing that if your itch is relatively acute, less than 6 weeks, or honestly, even a year, less than a year, let's say, you have to worry maybe there could be something serious internal, right? Could it be a
Mm.
cancer? Could it be some like new autoimmune disorder? Could it be, blood disease, something like that, some
Mm.
kind of infection? And so in those patients, I often will check a very wide blood work panel, specifically if they've never seen a primary care before. But even if they have, because primary care is focused on different things, I will check lots of different factors like a thyroid function, like diabetes, like a mast cell index, if we're thinking more hives. I mean, there's lots of different tests that you could order. But then if a patient comes in, and I see a lot of these where it's like 5 years of this, which is like so sad to even think about, people essentially it's very unlikely they have something internal going on because it would have presented in other ways. You're not going to have cancer for 5 years and have no idea about it because it's going to have caused other problems in your life. And so in those scenarios, it's more of a skin problem. They may still need internal medicines to fix it, but it's essentially your immune system is functioning incorrectly and it's attacking your skin or extra revved up in your skin, I guess would be the best way to put it, even though you may see or not see something on the skin.
Hmm. So, when it comes to, I guess, the psychodermatology, for any of the listeners that are not in medicine background, how do you explain that in everyday language, even just to patients?
Yeah, absolutely. I think this is super important, especially because historically, sometimes I think the way that we phrase it makes patients feel like, oh, you're just saying I'm crazy, right?
Hmm.
Or you're saying this is all in my head. And I think that phrase, particularly, I think is funny, right? Because it's like, in a way, everything is all in our head, right? Like our brains control everything that we think and feel. So yes, it is in your head, but so is everything in life.
Right.
And so I guess what I'm trying to say is, psychodermatology and inflammatory dermatology, they kind of go hand to hand, meaning that your nerves transmit itch signals to your brain that make you scratch. And so if you have a primary neuropathy, people often will think of like, numbness and tingling like on their feet, like in a diabetic. Like that's one version of neuropathy. But another version of neuropathy is pure itching. Those nerves are firing, they're sending itch sensations to your brain, even though there's nothing making you itchy. But then you start scratching in those areas and you're going to introduce allergens and bacteria and other stimulants that are going to rev your immune system up and cause a rash, even if you didn't have one before. So it's like you're ending up kind of like with a dermatitis or an eczema, but maybe it started with a more neuropathic,
Mm.
neurology type of problem. And then it goes the other way too, right? If you have pure inflammation from eczema and you're scratching a lot and you're barely sleeping, then you're going to mess with your brain chemistry. I mean, you're going to be sleep deprived. Your neurons become hyperexcitable, is the term they use for that. So any little thing that maybe a regular person would just kind of like rub their skin and be like, oh, that's done, is going to make you feel this incredible, intense itch, even like a bug bite that maybe
Hmm.
someone just thinks is no big deal. For that person, feels like it's the end of the world. And it's not that they're crazy or it's in their head. It's like truly their nervous system is overexcited. And
Wow.
so I tell people, not to feel stigmatized, like, other people may have told you you're crazy or you may feel like you're crazy, but you're not. I mean, this is
Hmm.
this is just part of our biology, and there are a lot of different ways that we can fix this. Being holistic with both the inflammatory and the neuropathic, oftentimes I'm trying to use medications when that's the case that can help with both, right? So I really like medications that a lot of patients are familiar with, like gabapentin, because they use that a lot for like nerve pain, but gabapentin can help significantly with nerve itching and with any itching. So
Mm.
let's say you have severe eczema, and might be putting you on something like a Dupixent or like a Revoke or something like that, and the Movio. I mean, those got so many options, right? But then I may also give you gabapentin to take at night because I know it'll make you feel sleepy, it'll calm
Mhm.
down the nerves, and you're kind of attacking it from both pathways to get patients better.
Yeah. Wow. Yeah, I like that approach and that makes so much sense. In the industry, there's so much education that is needed or there's a lack of education in the medical office, in the derm office. And how do you educate your peers, but then also how do you educate your staff as well? Do you feel that's important for them to understand how to approach these patients?
Yeah, honestly, I'd say with my staff, especially the ones that work closely to me, it's almost like a leading by example. Like they see how hard I fight for this and how seriously I take it, and it makes them want to take it more seriously. But then also just the experience, right? Like those patients who turn for follow ups and are better, they're endlessly grateful. They're in tears sometimes, giving the staff and me hugs. And it just like that feeds back into like, wow, like look at this impact that we made by caring this much and by treating this patient seriously. And it makes the staff care more. The trouble sometimes is more with clinicians, honestly, than anything like other docs, PAs, and MPs in my practice or just in medicine in general who may not see a lot of itching or again
Mhm.
may have not historically placed a lot of importance on that. They may think it's like not so much of a big deal, right? So they may be scared of the medications, right? Oh, these are new medications, or I got to check blood work or injections, or I don't want to bring this up to patients because I'm afraid that they're gonna be upset at me or that they don't want this. But so that is more education, like you said, whether it's in conferences, whether it's in press, whether it's awesome podcasts like your own, so many different ways that we can learn, and just saying like, hey, this is out there. This is what clinicians who are taking care of these conditions on the front lines are using. This is how we use it. This is how we fight for our patients. Kind of demystifies the whole process so they feel more comfortable.
Yeah, absolutely. So you work extensively with skin of color as well. What is a misconception in dermatology that you would love to correct?
Yeah, I would say probably the number one thing for skin of color is that rashes, even itch itself, but let's say rashes just more broadly, can appear very differently in skin of color. So we have awesome textbooks now, we have awesome conferences that are dedicated to this, but historically, a lot of dermatology education has been on purely Caucasian skin. And so for some people, let's say you train somewhere where you mostly see Caucasian people and you train using textbooks and lectures, et cetera, of Caucasian photos, they really struggle if they move to a diverse city, because then you're seeing people of all different skin types from all different places around the world, and you say, oh, I don't know what that condition is, or you call it the wrong thing. And that's where I say I have a lower threshold to biopsy in my skin of color patients. Again, I want to get them the correct diagnosis, and if it doesn't look classic, then that's one way that I can do it. And then also because the hues of the skin look different, really, really severe skin inflammation can look somewhat muted, especially in our darkest skin type patients, or like our, Fitzpatrick 5 and 6 patients. And so sometimes they get brushed off, right? Like, oh, your skin is just a little dry. Like if that same rash, quote unquote, right, was on a very light Caucasian person, they would look beet red, and someone would be maybe admitting them to the hospital.
Yeah, it's important to know the difference for sure. I mean, it has an effect on how patients feel when they come into the office as well. So when you look at like the evolution of dermatology treatments and patient access, what most excites you about where the field is headed?
Yeah, I'd say the exciting things right now are drug development, right? Like industry seems to really care about these conditions where our patients are suffering, even if it's not necessarily life threatening. They're inventing new medications, they're enrolling clinical trials, they're supporting peer to peer education programs, conferences, et cetera. So, like, that's a really exciting thing. I'd say what is a little exciting and hopefully going to be more exciting moving forward is hopefully some positive government intervention in terms of step therapy, making sure they're being reasonable, not making you try 10 non-FDA approved dangerous things before you get the one good treatment. Also having more regulations about how long they respond to the initial authorization or to an appeal, because some companies, as you know, right, are excellent. It's like within 48, 72 hours you get some kind of determination or they even answer an appeal. Others, I mean, we have one in my area that it could be 2 months and they have it's
Mhm.
crickets. And then of course what ends up happening when you reach out to them, oh, we never even got this, or oh, we got this but it was at the bottom of some pile somewhere, and it's like, come
Mhm.
on guys, we're in 2026 now. Like, so that's something
Yeah.
I hope that the government maybe can get a little bit more regulated with. And then, other thing advocacy wise is trying to put a more education in the hands of patients, whether that's commercials, whether that's support with these specialty things coming from primary care offices, just so patients know these conditions can be treated, that these medications exist, that they understand the process especially, I hear a lot of patients saying like, oh, the pharmaceutical industry is evil, right? Or like in medicine, like medicine's evil, like they just want to like throw stuff at us, but they don't want to fix us. And they don't realize that honestly, half the time, like our hands are tied behind our back, right? It's like we're
Hmm.
not able to give them the best treatments. It should be our power as like the people to say like we pay for insurance our whole lives, or company or someone's paying for it, right? And
Hmm.
there should be some degree of control with that. Like obviously, of course, I believe in freedom and capitalism, right? But like for example, in some countries, there's a cap on how much profit insurance companies can make, or they're
Right.
nonprofit organizations. They're still paying their employees, doing all these things, but they're not beholden to shareholders. This is not like luxury vehicles, right? Like you can choose to ride a bike or drive a Ferrari, but like you can't choose to get basic health care.
Right. Yeah, it's so true. I mean, I think there's so much education that's needed. And I like what you said about maybe commercials that can provide some education because you don't see that at
Yeah,
all. You see commercials about the drug. And then I think what most patients or people pull from it is the very tail end where they talk about the risks. And
yeah,
I think
correct.
that's what gets people freaked out, and they're like, yeah, but if they don't understand that they actually legally have to put that in there, that doesn't necessarily mean that that's what happens, but they don't know that. So
You're right.
more education about access to these treatments and the benefits of the treatments, but I think that is huge, and that's something that I have seen, of course, over the years, that there's a lot of offices that are like, okay, well, we don't want to deal with pharmaceutical companies. We don't want to have to deal with the drug
Mm-hmm.
reps that come in. And, but when it comes to these medications, they can be life changing.
Yeah. No, education plays a huge role. To your point about the access, it's still mind boggling to me that the kind of process has been somewhat stable for the last decade or so, right? But I still hear patients, let's say a commercially insured patient calling in and saying, "Hey doc, I don't know what to do because that's going to cost $3,000 a month and I can't afford that." And they've spoken to like 10 different players in the chess game, and no one's playing the copay card to them, right? Or like that there are
Hmm.
discounts or that there are, assistance programs. And again, like these things should all be explained. We have too complicated of a system, but that's why we're awesome people. Biologic coordinators, I think, are invaluable to offices because they help serve that role in a detailed way. There can be more confident because sometimes, like we had a system for a while where we didn't have a coordinator. Just our medical assistants kind of like piecing things together. They didn't know all the rules and all the nuances, so it goes both ways, right? They can tell a patient, "Hey, the medicine's going to be easy and free," and then when it's not, they're disappointed, right? Because of X, Y, or Z nuance. And then on the other end, they could not be getting treatment and qualify for easy free treatment because they just didn't know.
Right. Yeah, it's so true. I think there's got to be education on all sides. One, I have a question for you. With all of these new, I guess, portals and with AI technology that's coming out to do the prior authorization, do you think that something like that can replace what the coordinator does? Because I feel like a lot of times people think, oh, it's just the prior authorization. And that's not
Yeah.
really what delays the patient
Oh,
care.
yeah. I think the people who think that is because they don't know the process well enough, right? Like,
Mm,
I think AI can help with some very basic things, but you
right.
really need that human touch, that advocacy, that fighting for it, that ability to communicate, whether it's with the payer, whether it's with the patient, whether it's with the pharmacy. And so I don't believe it could ever be replaced. And I think people will try, of course. And
Hmm.
I think they're going to end up giving patients inferior care because of that, the realities of our system.
Yeah, absolutely. So when it comes to patients, when they're waiting for appointments, they're used to waiting long times or feeling rushed. What do you hope they notice when they first experience the care built around respect and attention when they come to your practice or come to see you?
Yeah, for me, I think it's that I'm going to give them the time that they need. So it's, that helps, particularly when I'm running behind, right? The patients understand, yeah, they may have been waiting an hour to see me, but I'm going to spend the time with them that they need. So,
Hmm.
and because I do that with everyone, sometimes that does make me run behind. So I think it's letting them know that I deeply care based on that, right? And occasionally I have a patient say, who, oh, well, that doesn't work for me. I say, hey, you booked the first visit of the morning, right? Or the first one of
Hmm.
the afternoon, and then you make it, then you know that there's no one before you, right? So
Right.
that's something I try to communicate patients that I'm one of those clinicians where it's like I'm going to take all your issues seriously and I'm going to spend the time with you. And of course, that makes me be slightly less efficient than someone who's like, all right, you can discuss two things with me only, and we have exactly 7.5 minutes.
Hmm.
And I
Yeah.
think everybody knows what kind of care they prefer, right? And then I
Right.
think people self-select for these things. and that's really how it goes. And I think the patients, once they get to know me, they understand that,
Hmm.
and they know that I will fight for them. And so, we're not perfect, right? When people, staff may call out, people may be sick, traffic may happen. I think it's just being understanding, having understanding of
Hmm.
culture, caring culture.
Yeah, absolutely. So you have a popular social media page. It's called Married to Dermatology. So
That's
when I
right.
first saw that, I was like, oh, he's like all in dermatology, but your wife is also in dermatology.
Yeah, that's right. Yeah, so it's more of a play on both, right? It's like, yeah, I'm married to dermatology, so I'm super passionate about this. My wife is literally married to dermatology, being married to me, and she's passionate about skincare as well.
I
So,
love it.
we kind of like tag team a little bit. She is super into the more of the aesthetic side of things, and so she tries a lot of the products that I bring home or things that I recommend, and helps me with some of my before and after content and that sort of thing. And then I talk about more about the medical stuff that I do. But yeah, I'm always showcasing things that I'm passionate about there, whether again it is access things, whether it's medications, whether it's some of the aesthetic stuff, because again, I also think that's very important. And yeah, they definitely encourage folks out there listening, if they're curious to follow my journey or learn a few things, definitely give me a follow.
Yeah, I mean, I think obviously it's a great way to get to know patients, but also see what people are actually wanting to learn more about. What are your thoughts on a lot of the skincare trends that you're seeing when you get on social media? And do you try to debunk a lot of that stuff, or, for your followers? How does that work?
I hate to like discourage people from things, particularly if I don't find them to be harmful, right? So
Hmm.
a lot of trends are not necessarily harmful, right? They include deep moisturization, include, maybe washing your face less than usual, double cleansing, single cleansing, cleansing every other day. I mean, you can see like every different variation of different things, right? Using certain products in a row, or stacking. So if something's not harmful, I learn from these things, even
Hmm.
from people who are non-dermatologists, and I like to try new things and experiment. But what I do fight against sometimes, if something seems to be harmful, right? Like people using these acid toners in high percentages, sometimes even things that are not like necessarily available in this country, they're getting from other countries, bleaching agents, being too aggressive with their skin or scrubbing the heck out of their skin using abrasive substances. Then again, I want to fight against that because I don't want people to harm their skin.
Hmm.
And then misrepresentation. I think that's something that I really hate sometimes in our world now. I think there's a lot of great information out there, but there's also a ton of like, oh, try this serum, look at this before and after. And it's like obvious the patient had like plastic surgery and laser and like 17 other things, right? Because it's like impossible that,
Hmm.
and I'm like, well, yeah, that's so mean. Someone watching this thinks like, oh, great, I'm going to buy this product and I'm going to look 30 years younger. I'm like,
Right.
let's be realistic with what things can do. So I try to spread that realism, but also keep it playful and not shut patients down like, oh, no, you can't use any of that.
Yeah, I know. Well, now I feel like there's even a bigger barrier, or at least a battle, because there's so much AI, and half the time you're like looking at a video, I'm like, is that AI or is that
You're so
real?
right.
So
You're so right.
you
It's
don't know
scary.
the
Yeah.
difference.
Yeah, unfortunately, it's scary. It's an interesting world that we're entering. I don't have, honestly, a lot of answers about that. Even having like, an expert discussing something. I
Hmm.
mean, you have these like deep fakes where they can have like an actor discussing something, and it like sounds like them, and it's their voice, and it looks so natural and real, but it's like not actually them, and
Hmm.
it's kind of scary. I think it just means that we can maybe trust if it's something someone we know, but always verify, right?
Right. Yeah, because you're not going to learn everything just from your textbooks.
Correct. Yeah.
So I was saying, just being knowledgeable, particularly because things are evolving so quickly. And, I'm less than 10 years out from training, but yet so many things are so different than even, 10 years ago or 5 years ago. And so
Hmm.
I can only imagine in 20 years, right? I've been practicing for 25 years and things will be very different. And I don't want to be, as one of my great mentors, Dr. Scott Drew says, you don't want to be a paleo dermatologist or a dino derm. Uh, you know,
Dr. Drew is great. I love
oh, I
him.
love him. Yeah, he's the best.
That is good. I was going to ask you, where do you continue to learn, and are there other physicians that you follow just to stay up to date and to make sure that you're not missing things?
Oh God, there's so many different avenues. I feel like we're spoiled in that way in this
Hmm.
digital age. That's one of the positive things, right? So for me, there are, of course, all of our conferences, the Fall Clinical Series, the Maui Derm Series, the AAD, South Beach Symposium, another fantastic one. There are many, and then online resources. I like podcasts. Of course, that Derm Good is a great one. I like Dermosphere. I like Derms and Conditions. Many other great podcasts out there too. Other online resources like Vumedi videos, Scholars in Medicine. And then there's, of course, the old fashioned way, which I still do too, reading journals, right? So I have a handful of journals that I try to read every single month.
Mhm.
And then keeping the pulse with my colleagues too, that maybe, have like, if my little micro expertise is in itching, right? So my colleagues, it's in vitiligo or it's in psoriasis or whatever. So like being in contact with those folks. And I have numerous mentors who teach me a lot, and asking folks, hey, you ever seen this condition, or hey, have you ever used this medication in this way? Have you ever seen this side effect? I think it's a lot of collegiality we see in derm, and I love it because
Mhm.
the patient wins.
Yeah, absolutely. So besides all of the things that you're doing, I mean, besides, writing articles, speaking, what are some things that you do personally to keep your health up and your mental side? Like what do you do to relax and to
Yeah, for me,
just take a
it's
break?
totally keep it pretty simple. It's my family. So again, I'm married. I have a 6-year-old son and a 4-year-old daughter. So I think whenever I have extra time, it's hanging out with the family, whether it's throwing a football around outside, kicking the soccer ball, going for a run, or just playing with the kids, board games, watching movies. We love our family movie nights, cooking with the
Mhm.
family. We love to travel, and we take the kids a lot of different places. So took the kids to Paris last year, which was really cool. My wife and I will go on solo trips to like Africa. We do some like medical and veterinary missions because she's a veterinarian. So I think it's
Wow.
just keeping life pretty fun, and doing different things. So it's like I don't feel like I get into that monotony where I'm just doing the same thing every day, for a year
Mhm.
straight.
Yeah, that's exciting. That's good. Got to stay grounded some way.
Yeah, seriously, yeah. And just having like friends outside of medicine, where you just chat
Mhm.
about
Okay,
sports.
so right, sports, yes. I know. I just recently went to my first live football game, and I will say I never really was I never I mean, my husband watches football all the time, so I've got to watch it, but being there live is completely different from watching it on TV.
Yeah, right. Isn't that the case? Yeah, 100%. It's funny. I mean, I don't mind like certain sports I watch on TV, but when you're there in person, it's almost like any
Mhm.
sport you can get super into, right? It's just like
Yeah,
the crowd is excited, there's some good food, it's like there's
right.
like a lively atmosphere. Yeah, it's
Yeah,
a good time.
I know. I told my husband, I was like, all right, we'll have to do this again. So he got
Yeah.
excited because now he thinks I love football.
Right, exactly. Yeah.
So, what is one myth about dermatologists or dermatology that makes you laugh?
Probably that we're just pimple poppers only, right? I mean, I think obviously we started the podcast talking about acne. I think it's super important, right? But like people
Hmm.
don't realize obviously the million other things that we do, right? Like we're surgeons, we're laser surgeons, we do the aesthetics, we do aging skin and skin changes in terms of like all these rashes and itching and autoimmune disorders that come as you get
Hmm.
older. But we also treat babies. And I think it's just the variety of what we do is not known by the public or even sometimes other specialties in that
Yeah,
whole house of medicine. So I think that's what makes me laugh sometimes.
that's great.
And
That's
and
amazing.
I think the other thing is just that like that what we do is easy because I think at the end of the day it's a ton of like pattern recognition and seeing different skin conditions like hundreds and thousands of time over your career. And
Hmm.
I think the easiest way to know that it's not easy is like when you like if you're an untrained person, especially when you see a spot and that you think is bad, and then you come in and I look at it and say that's completely fine. It's benign keratosis, and that spot that you thought was nothing, that one's the melanoma. It's
Hmm.
humbling. And even my
Yeah,
friends who are doctors, brilliant people, neurosurgeons, orthopedic surgeons, etc. They send me pictures all the time, and they're like, "Oh, do you think this is a problem?" Like, no, it's completely fine, right? Like, are they dummies? No, by no means. But it's just every field is its own challenge, and it takes a lot of practice.
yeah, yep, absolutely. Well, thank you so much for joining me. It is such a pleasure to talk with you, and I'm so thankful for all that you do and helping your patients and putting their minds at ease. When it
Yeah,
comes to these chronic conditions, whether it's acne or any chronic skin conditions, but I think there's definitely a lot of room for education, and you're definitely doing that. So I appreciate all that you do.
yeah. Thank you so much, Janelle. It was great to chat with you and to be able to share some of my experiences. So thanks so much for having me on.
Yes. Well, maybe I'll see you one of these conferences.
Yeah, hopefully I'll see you around. Yeah.
All right. Take care.
All
Thank
righty.
you.
Take care.
Thanks for spending a few minutes with me and listening to That's Derm Good. You can expect new episodes of That's Derm Good every week. The podcast is available on your favorite app, including where you're listening right now. Subscribe to the podcast so you never miss a new episode. Bye.